Thank you, John. Excellent lecture. Number one, do we have to worry about anything if the wear is chemical? Chemical wear of the teeth, I guess, John.
Absolutely, and I think that the problem is, David, how do you figure out if it's chemical or not? How do you figure out if it's chemical versus mechanical? So what I've started to use in patients like that you've seen presented here this evening, especially that young 35-year-old gentleman, and remind me to share with you, I just got the GemPro results in. He has severe, some of the highest magnitude of force nocturnally I've ever seen since I've used the GemPro. He had no SpO2 desaturations. So what does that tell us? He has nocturnal parafunction. But I also use a product from GC. It's the GC Saliva Testing Kit. It tells us acidity, and it tells us quality and quantity of saliva. So when I see someone that has severe wear, I want to figure out chemical and mechanical. So how am I going to do that? Chemically, I'm going to use the GC Saliva Test Kit. Parafunction-wise, I'm going to use the GemPro to figure out if that parafunction is associated nocturnally. If it's not associated with nocturnal parafunction, then my logical brain would say to me, it has to be associated with a diurnal parafunction of some sort.
Okay, next question. Does Cpap reduce bruxism?
Oh, I think I saw some of the attendees. I think I might know who asked that. The answer is, based on some of the literature I've read, that it does. Other literature that I've read, it says it doesn't. So I don't have a finite answer on that. And so I'm going to plead the fifth on that.
Okay, that's fine. You're allowed to do that. At least in Canada anyway. We're nice people up here.
I know that.
Hey, next question. Which one is worse in breaking implants and screws? Nocturnal or diurnal bruxism?
That's a great question. So I'm thinking how I want to respond to that. Since I've been involved with implants since 1982, and I have multiple patents on implant prosthetic components, I think both forces are destructive to implants. I have not seen any studies in the literature. In fact, the study that first came out that I cited was one of the first studies I've seen that related airway and implants. That's why I wanted to present it. So here's what we need to figure out. If you have parafunction and you place implants on a patient, in a patient, if you restore them with implants, I think you have to figure out whether it's nocturnal or diurnal. So let's assume it is nocturnal and there is only parafunctional activity and they have no SpO2 desaturations. They have a little bit of snoring. How am I going to treat that patient? I'm going to treat them with an appliance. And what is my appliance going to be? Either 2 flat plane maxillary and mandibular splints or a Herbst. If they have no nocturnal parafunction, and this is the way I do all this is with the GemPro. And the beauty of the GemPro is you can do multiple night studies without having the patient come back, and it's very cost effective. So assuming that they have no nocturnal parafunction, that would lead you to the assumption that they have to have diurnal or daytime parafunction. If they have daytime parafunction, the only thing that I have found based on my experience of 45 years of doing advanced prosthetic cases is either they wear some type of daytime appliance to protect the teeth and no one wants to do that, or you get them involved in CBT, cognitive behavioral therapy. Great question.
Okay, thank you. The next question will probably stretch it a bit in terms of going outside our profession, but is CPAP and oral appliance therapy the only way to treat airway problems? CPAP and oral appliance the only way to treat airway problems?
Absolutely not.
Okay.
That's my personal opinion. Inspire, the STAR trial started back in 2010. Vander Veeken, Ryan Seuss in Pittsburgh, dear friend of mine, I've been enamored with that treatment since it first came out. Because what it does is it's hypoglossal nerve stimulation. So in the STAR trial, they use DICE, drug-induced sleep endoscopy, using propofol in a very specific manner. I can't get into that, to figure out where the airway collapsed. And that's when they talked about multi-dimensional collapse of the airway. So if the patient has primary collapse at the level of the epiglottis, they would certainly not be a candidate for hypoglossal nerve stimulation. Hypoglossal nerve is the 12th cranial nerve. We know that when that is stimulated, that compacts and protrudes the tongue to get it up and out of the airway. That's why Inspire was developed. So those two things, just CPAP and oral appliance therapy, those are two great treatment options, but we can't cookie cut. Everything has to be tailored to the patient. What are the patient's desires? What are the specific treatments that would work for that patient? So let's say a patient won't tolerate CPAP. Let's say they won't tolerate an oral appliance. Well, then my next thing would be, well, we can talk about trach. I'm not even going to go down the road of UPPP because we know what the literature says about that. So I'm going to think about Inspire. So if the patient is interested in Inspire, there are certain protocols and parameters that have to be met. Some insurance companies say the BMI has to be 35 or less. Other insurance companies is 32 or less. Then the next thing that they have to do is they have to go through DICE. Like I said, drug-induced sleep endoscopy. Find out where the collapse is. If it's primarily tongue-based collapse, then and soft palate, because there's some new literature that's come out about that, then they're candidates for Inspire. And the cool thing was when I went through the cadaver training, I was one of the first people trained to go from a 3-incision technique to a 2-incision technique. So I actually wanted to sign up myself. I mean, everybody knows that knows me knows that I have obstructive sleep apnea. Unfortunately, my airway's not bad enough anymore. My AHI, my last test 3 weeks ago, was 4. And your AHI has to be greater than 15 for Inspire. So I apologize for the circuitous nature of my response. I think, once again, to reiterate, the treatment has to be specifically designed for that patient. It's not always CPAP that's going to work. It's not always oral appliance therapy, and it's not always Inspire. Maybe it's a combination of, you would never use CPAP and Inspire, but you could use oral appliance therapy and Inspire.
Okay, take a big gulp there, John, because we've got more questions. You excuse the pun, but if you could inspire our audience about Inspire, we had a ENT surgeon speak on DICE a few sessions ago, and she very quickly said that she didn't see a future for Inspire in Canada because of regulatory hurdles that doesn't sound like we're going to be easily overcome. So we may never see it, I understand. So could you just give our audience a quick overview of what Inspire is? And is there an alternative that might be applicable to Canada?
I will check with the powers that be at Inspire. And I've gotten very close to a lot of people there. And I'm very blessed to have had that happen. I don't see why Inspire wouldn't make it there, David, but I have to get back to you on that. I can't comment on that, but here's the comment I have for you. We know that David White and his group have done some work with medications and Airway. You know, problem with that is that's totally outside our scope of treatment, right? I would never want to play with medications with a patient. And I'm not going to get into that whole study that David White did with the medications, but that's a possibility. So I think if Inspire's not a possibility for you, for those patients that don't want to have CPAP, they don't want to have an appliance. So I said, so what are you going to be stuck with, a trach?
Pillar implants were big in Ontario, at least some time ago. They seem to have fallen out of favor. You're shaking your head, so tell us what you're feeling about that.
So it's really funny, David. I've been so blessed on this journey. When Medtronic had the pillar implants, there are a group of dentists that were invited to participate at in Minnesota, and we were trained by Frank Rimmel, who was the head of the ENT program there, and we placed pillar implants on cadavers, and it was really neat. And we got to use an endoscope, and I said to Frank, I said, man, that is so cool. I would love to do that. He said, well, why don't you use do me? I said, you're gonna let me use an endoscope on you? And he said, of course. So, I mean, it was so cool I got to do that. Here's the problem. There's no really good data that supports how well pillar implants control the airway. And I know the theory. First, it was 3 pillar implants, then it was before placed in the soft palate.
Right.
And, you know, I've not seen any great data to support that. And I've seen lots of failure with pillar implants. I mean, I placed probably close to 50 myself, and did not have good success at all, and had quite a few failures. And then now I'm stuck trying to take out pillar implants in the soft palate. And then how do you think I look sending those patients to an ENT to try and help me out? Didn't bode well.
So you're allowed to place them as a dentist, but obviously recover them surgically is not a dental procedure.
Outside of my comfort zone.
Right. Okay. Okay, back on the trail of questions. Let me see now. If a patient doesn't have OSA, why would you use a full arch stabilizing splint when you know that your molars have a heavier load than the incisors? Does that question make sense? Did I do it right?
Kind of, sort of. And I think I know where that's coming from. I think I pretty much proved that, you know, flat plane splints don't work. And I was trained on that. Remember, I mean, God love Pete Dawson, God rest his soul. He was a dear, dear friend. Talked to Pete countless times, hung out with him hundreds of times. I mean, that was a big thing. We all made flat plane maxillary splints, right? And then that work came out by Gilles in your journal back in 2015. And my thoughts are this: if we're going to try and treat parafunction and it's nocturnally related, I would prefer to have the way I look at it is 2 ice skating rinks against each other. Minimal vertical opening, so 2 flat plane splints, one on the maxilla, one on the mandible, to allow the mandible to go wherever it wants to go throughout the night and protect the dentition, assuming they don't have a sleep-related breathing disorder.
Okay. Another question that I'm not sure how you want to answer this. What ODI number do you use to trigger your referral to a sleep doc?
It's a great question. I don't get stuck on ODI numbers as much as I do the percentage of time they're below 90. all right? So if somebody is at 72% for 15 minutes, you've got a major issue and you have no business treating that patient. So that's data that you can get from GemPro in real time. And so if I see somebody that's desatting to those levels, I run them to a sleep physician.
Okay. While I wait for more, almost every time we've had the pleasure of a Canadian-friendly American professional like yourself, we have to remind you folks how vastly different it is to practice dental sleep medicine in Canada.
Correct.
I'm fairly well known in London. I'm in the same town I graduated from. I go to sleep rounds monthly. I present there. We have a medical school and a dental school, and the wait list for a PSG in our local hospital is about a year, and you can count on 6 months to get the sleep physician to report the findings. And there's not a lot of collaboration between our two professions, despite the fact that I've worked really hard to try and build this big tent, as I call it. Right. And so many of us are jealous of the system you have, because once you get it all set up, it can work really well. Our patients in Canada have to pay almost 100% of oral appliance therapy because there's no coverage through our socialized medical system. And even our own dental profession, after 10 years, still can't find it in their hearts to even put a figure on a value. So insurance companies just say, well, if you can't figure it out, we're not going to cover it. So it's an uphill battle. The patient can get a CPAP machine for about $350 or pay me $3,000. Pretty tough. What's it like down there? Should I move to Erie? Should I come to Erie?
You don't want to come to Erie.
Okay.
It's better in Canada. So here's the big thing. The same thing holds true in Erie, PA as it does in Canada. It's now a 6 to 8 month wait to get somebody in to see a sleep physician. I blame COVID for that. They really are not concerned about sleep anymore. They're more concerned about their pulmonology. This is the pulmonology group I'm speaking of, right? And to be honest with you, you got to follow the trail. They get reimbursed a lot more for treating a COVID patient than they do at looking at a sleep-related breathing disorder patient. So that's changed. And when I talk to patients about sleep, they don't want to wait 6 or 8 months to go to see a sleep physician. I've always advocated that we work in concert with our peers. It's a medical disorder with a dental component.
If you have a mid-face deficiency and you know there's no AHIs, do you believe that cognitive behavioral therapy can be an effective management?
That's a phenomenal question. CBT could be a component to that, but I mean, now you're talking about skeletal issues, right? And CBT was never designed for that. So perhaps you need to look at depending on the age of the patient, ways to correct that orthodontically. And we all know that there is a huge orthodontic component to the airway, but I wouldn't look specifically to CBT for that. I might want to think about myofunctional therapy as a component to that. But the bottom line that I'd like to add to my comment is this. Most of the patients we're looking at, it's a multidisciplinary treatment. So it's just not one treatment fits all patients. Like I said, we don't cookie cut. Myofunctional therapy is great. CBT is great. Cognitive behavioral therapy, not CBCT, okay? People don't like to change. And one of the things I've seen, and I've been doing this for going on 18 years now. And I don't mean to get sidetracked or take another circuitous route to answer a question. I ask patients, are you willing to get better? Because one of my best friends is a physician who helped me understand more about sleep than anyone else, because when I started in sleep, there were no dental textbooks written about sleep. It was all a medical disorder. He said, Tucker, be really careful. He said, what you need to understand, there are a lot of patients that just don't want to get better. I was like, wow, that's pretty amazing. He said, do you think that every patient takes their blood pressure medication the way they're supposed to? And I said, of course they do. He said, let me ask you this question. Do all your patients floss and brush the way they're supposed to? And it's like, oh, right? That hit home. Does that make sense?
Right.
So I think we have to look to every different component in the patient's treatment that's going to be of benefit to them. Now, here's the big question. I recommend a lot of patients and send a lot of patients for cognitive behavioral therapy. Do many go? No. I recommend myofunctional therapy. Do many patients go? No. So I guess the older I get, David, when I was young, I used to say, oh, I draw a line in the sand. Well, my new line is, I have a moat. And the older I get, the wider and deeper the moat gets. So that means that I have to put the drawbridge down over the moat to allow you to come through for treatment. And if I sense that patients don't want to get better, oral appliance isn't the magic bullet. Inspire's not the magic bullet. Cpap's not the magic bullet. They've got to want to get better themselves. And I will get off my podium. I'm not trying to preach. I'm just trying to give advice to people that are young into this, to don't get caught that you're going to be able to help everybody get better, because some people just don't want to get better. And I see people just don't want to change. Change is hard. Yeah,
no, you're absolutely.
You have somebody that, I had a young man in this week, CPAP intolerant. He's 27 years old. He weighs 430 pounds. He can barely breathe in my chair. He drinks 16 Mountain Dews a day. So does he have mechanical wear, or does he have chemical wear? Or does he have a combination of, he's a train wreck.
Right.
And I said to him, do you want to get better? He said, well, I know I need to lose a couple 100 pounds. I said, well, saying that you know that you do is, I'm glad that you admit to it, but what are you willing to do to make that happen? Because my appliance isn't going to make you any better.
Right.
So that's my advice for that. Sorry about that.
No, that's fine. Sometimes the best learning takes place in the hallway. So this is our question and answer period. An expression came to mind in your conversation. I think it goes something like this: when the patient is ready, the doctor appears.
Amen.
When the student is ready, the teacher appears. And our last presentation with Dr. Murphy from Prosomnus, because he's like you, very connected to the medical world. And I brought up the point of, we dentists are trained to be expert engineers. We fix everything up with our own hands right in front of us. It doesn't leave our office till it's perfect or as good as we can get. Everything I do in TMJ and sleep therapy, I make it and I send it home. I don't have a clue if they wear it or don't wear it or put it in backwards. And he talked about his daughter, who's not a dentist, but works in the system. And I think was bringing over the medical thought process that you just talked about. And she said something about, Dad, you've got to harden your heart, because what you do in the chair, yes, you may control and you may want to do a really good job, but all these people leave your office and you don't know what they do. But you take it as a failure when they don't succeed. And that was a hard thing for me when I got out of general and got into this. Like, you're not listening to me. You're not doing what I say. You're not wearing your appliance. You didn't go to the osteopath. You didn't, all that stuff. As they say in New Jersey, don't get me started already. One more question that looks like it's a structural one. Forward anterior head posture is a critical factor in suboccipital muscle contraction, which can cause increased sympathetic tone that increases unconscious wakefulness that initiates parafunction. That's a statement, not a question, but I know you can talk to it.
And I'm
Forward
pretty
head
sure
posture.
I'm pretty sure I can figure out who asked that question.
This is anonymous in Canada. We never.
I know that, but
Yeah.
I saw some of the people sign on. So
Well, you're not supposed to know how to do that, but anyway, okay.
Anyway,
Yeah.
I'm not going to take the bait.
Okay.
I've gotten very involved in heart rate variability. And heart rate variability controls sympathetic and parasympathetic tone. Probably the guru right now with that is one of my best friends in the world, Jeff Hinden. And Jeff Hinden, I do HRV, I use his equipment. And I've seen people, we have videos of this. Jeff's been to Erie countless times, been to his office countless times. We've seen people, stroke victims, that could not walk up and down the hall without holding onto both sides of the wall. And, you know, you put this magic bite in their mouth and they can walk straight up and down the hall. So, you know, that's a lot of work from Brandon Stack. And I'm sure you guys all know that. So
Rest in peace.
Amen. God bless him. I think you can control a lot of that with appliance. I wear a daytime appliance. I wear an HRV appliance. I know this program's not about HRV, and you know Jeff is maybe somebody that you want to reach out to have him do a program. He's the guru. He's my go-to guy. He's the one that's taught me everything. So I think you can control all that when you start to control sympathetic tone. So with that, I just opened Pandora's box.
No, we'll close it for you. Okay, another two questions. Now I'm gonna be a little difficult here because in Canada there's this raging controversy over data versus data, but I'm going to use the plural. Is there any data on what percentage of patients who have mild versus moderate versus severe with a short lingual freedom? Any connection between a short lingual freedom and severity of OSA?
Full transparency, don't know.
Okay. Any data on those who did and what improvements were seen, if any? So I guess that's a pass as well. Okay, that's good.
I'll tell you who I would recommend you ask for that information would be somebody like Bill Hang.
Right. Excellent. I'm filling up my list for the next couple months. All right.
Bill's a great friend.
Yes, I've seen him as well, and he's a born-again orthodontist who's seen the light and has come out and is helping us all not get into trouble. I don't see any more questions. At this point, I usually open it up to oral questions. So does anyone want to ask directly Dr. Tucker any question?
Thank you. I didn't ask the last question to try and trap you, Dr. Tucker. I'm asking the question because so many young people believe that their financial success is leading towards putting in as many implants as they can in a person. The reality that I see as a pain doc is that a lot of patients have such structural problems that managing parafunction becomes a problem because their platform, their occlusal, their head platform is not stable. And so you start to begin to see the failures, especially in the posterior region. So I am not trying to trap you, but I'm really truly respectful of your experience because you've been around the block. You have had your successes and you've had your failures, and so have I. And so with all due respect, I would never try to line up a speaker to shoot him down, but I do ask what your experience is and how to guide young people who are out there practicing professionally, putting in implants, to be conscious of the variables that come in place in managing the parafunction.
Doctor, thank you for your kind words. And I apologize if I misspoke about being set up. You have no idea how your comments resonate to me. Excuse me. And as someone that's been very prosthetically driven since I've been 12 years old, I think about a phrase that comes up from Sir William Osler: what the brain doesn't know, the eye can't see.
True.
And the very high-end lab that I deal with for my complex restorative cases, implant cases, we've had the same discussion that you're bringing up tonight, that they're seeing all these implants being placed in places they shouldn't be placed, no concern for parafunction, and it's all about the almighty dollar. And we know that when greed, pride, and ego get in the way, and money gets in the way, things are done for the wrong reason. So I don't know how we educate the newer dental professionals on what's right and what's wrong. You sound to be probably similar to my era, and you do things for the right reasons. And I see things being done for the wrong reasons all the time. The case I showed you, the 35-year-old male. Not one implant should have been placed on that gentleman until he had a full diagnostic workup done. But what am I to do is, the case is referred to me, right? That's not the way to do dentistry. And I'm not proposing that. I'm proposing that we look at the total overall well-being of the individual. Why is the parafunction there? Why is the forward head posture there? What are we going to do to treat this individual that's in our chair right now? And I think there are so many things that are misdiagnosed, completely ignored, just for the almighty dollar. And I hate to say that, but I think, my dad graduated in 1948 from the University of Pittsburgh. And I see things, I don't know who's going to teach and who's going to learn what. And that's a big concern of mine. So I appreciate your question. And the answer is, I think we need to have good, honest, continuing education that helps those students that have graduated. I know for a fact that there are many dental students that graduate, never done one single crown prep on a live human being. That's just wrong, in my opinion. That's my opinion. So what do we need to do? We need to have what the brain doesn't know, the eye can't see. We need to enlighten them. The problem is, do they want to be enlightened, or do they want to have their wallets be enlightened? Therein lies the rub.
So well spoken. I thought our school was the only one that lets people graduate without having cut one crown on a human, but I guess it's a bigger problem than I thought. Okay, John, we are begging your indulgence. I know it's 9:10. You at least are living in our time zone.
I'm good.
Okay. Any more?
Hey, David, I really appreciated that question. And I think there's a lot to that. And I'm not sure everybody heard that, but I think it's a bigger problem than we all realize.
Oh, absolutely.
So I applaud Doctor's comment, and thank you for coming online and asking that question live. I appreciate it.
Well, I practice in Ontario, which I call the black hole of healthcare. And for 20 years, I've been doing nothing but putting pieces of plastic in people's mouths to get them out of chronic pain and keeping them from jumping off the bridge. and I have to look over my shoulder every day, all day long, because my college that I give money to protect the public is looking for a reason to get me. But any new young graduate can take a weekend course and drill a hole in a bone and throw in a bolt, and it's there forever.
Right.
I'm involved in it. I mean, it makes me crazy. So, as we say in French, sous le tableau, I'm under the table as much as possible. So yeah, there's a lot of things that have to be fixed, and sadly, it'll be after my watch for sure.
Amen. Mine too.
Well, you're much younger, my friend.
Oh, I don't think so.
Any other questions? It's just it's been a personal treat for me to actually bring Dr. Tucker, because we met each other years ago, and I just knew he was a speaker that we needed to bring to Canada. And as I said at the outset, we couldn't make it happen in person, and here we are doing it virtually. So thank you so much, John, for coming tonight. You've
My
stimulated
pleasure.
lots of questions. We may be doing this for some time, because I can't see an in-person meeting in Canada for at least 1.5 years. So I know where to find you. So we'll come after you if we need you some more.
And David, thank you for the opportunity. And you have my email address. Please feel free to share it with whomever would like it.
Okay.
You have my cell phone number. You can share it with whomever you'd like. You know, I'm very approachable, and I try and respond as quickly as possible. So I'd like to thank you and your hard efforts to make this a reality for everybody involved in treating these patients that desperately need our treatment.